welcome to this virtual roundtable where we will be discussing some of the key data that emerged from this year's San Antonio Breast Cancer Meeting. I'm Hope Rugo, Professor of Medicine at the University of California, San Francisco's Comprehensive Cancer Center, and I'm joined today by two expert leaders in the field of breast cancer and great colleagues, Dr. Jennifer Litton from the Andy Anderson Cancer Center and Dr. Joe Chen from the University of California, San Francisco's Comprehensive Cancer Center. Thanks for joining me today. So now at San Antonio this year, we saw an update of the really interesting Monarch E data, the adjuvant trial looking at abemaciclib versus not additional therapy combined with endocrine therapy in the adjuvant setting for 2 years in patients who had quite high risk early stage hormone receptor positive HER2 negative breast cancer. That data was first presented at ESMO this year and published at the same time. And it was the data from PALLAS was also presented at ESMO showing no benefit from 2 years of palbociclib. Same kind of trial design, but a lower risk group of patients. Very interesting data. And also at San Antonio, right after the Monarch E update, we saw data from PENELOPE-B that looked at palbociclib for just 1 year in patients with high-risk disease after neoadjuvant therapy. The update from Monarch E this time looked at the subset of patients who had a Ki-67 or greater and tried to see whether or not there was a differential benefit of abemaciclib in that group. Jennifer, do you want to summarize some of that data for us and tell us your take on it?
Sure. So the Monarch E, we get further update. When it was previously presented, it was a median follow-up of about 15.5 months, now at about 19.1 months of median follow-up. And interestingly, still only about 25% have completed the full 2 years. So we still need to watch this trial as it matures. The improved IDFS curves separate, and they're still separated with a hazard ratio of 0.713. And really interesting in this cohort, especially of the 1 to 3 positive nodes, but the high Ki-67 of over 20%, grade 3, these patients had a much higher benefit. It was almost a 4.5% absolute difference. So these higher risk patients are the ones likely getting the bigger benefit of the addition of the CDK inhibitor. The overall survival is still pending, and the distant recurrence-free survival stayed really the same at about 3%. And just like you said, right after the PENELOPE-B presents, and this was looking at palbociclib after neoadjuvant chemotherapy with residual disease with a median of about 43 months, and still no difference there. Interestingly, too, the PALLAS trial, which we'd heard as well, also looking at a very similar population, potentially less aggressive disease, and really interesting in the PALLAS was a 42% discontinue rate, which really puts it out of sync with both the PENELOPE-B and the Monarch E trial. And the ongoing NATALEE trial looking at ribociclib has gone on for 3 years. So we have one positive trial, the Monarch E, which gave abemaciclib for 2 years. We have the PENELOPE-B, which was essentially a negative trial with only 1 year of adjuvant palbo, and the PALLAS trial that had two years of palbo, but a 42% discontinue rate. So really still trying to put that all together, but at this point, we still have confirmation with further follow-up of a positive abemaciclib in this situation.
Yeah, I thought that the data on Ki-67 was quite interesting. And just to clarify, it was the entire trial population. So it included patients who had 1 to 3 positive nodes, grade 3 disease or a tumor of 5 centimeters or greater, and patients who had 4 or more positive nodes, plus the small cohort B, which is that 1 to 3 positive nodes and high Ki-67. And if you took all of those patients together and looked at the high Ki-67 group, that's where the 4.5% absolute improvement in DFS was seen, which again, I think is quite clinically relevant. And I think that the other thing that's interesting about all of this is the already difference in distant recurrence rates. albeit very short, outcome data, in terms of follow-up. And it's interesting because we think of ER-positive breast cancer as having this very long natural history. So you're basically plucking out the people who have an earlier recurrence risk. And I think that's really important when we think about this, is that PALLAS suggests, if we think about the agents not being agent specific, that the patients who had a low risk in the first 2 years of recurrence don't benefit. And so we're really selecting that group out. How are you going to take this into your clinical practice, Joe? Do you think we're ready to use abemaciclib as adjuvant therapy for very high risk disease?
I think we need to see longer follow-up. I mean, I think it's very unique for such early data to be presented, right? Like I'm trying to think of other studies where we're presenting data where more than 50% are still on the study. I think when we look at these results in context of PENELOPE-B, where at the 2-year IDFS, you saw a difference between the two arms that looks similar to the difference in Monarch E. And at 3 years and then further at 4 years, those curves narrow and actually now are crossing. Does that mean that duration really matters? That because remember in PENELOPE-B, you come off at 1 year, and that's when you start to see these curves narrow. I think we really need to wait to look at survival. We have to see, are we sort of pushing out and delaying recurrence? And is that because they're coming off the agent after 1 or 2 years? So I think it's not clear how these agents will benefit in the long term. Having said that, right now, as we are waiting for that data, what do we do, right? And I think these data are compelling. In my highest risk patients, 4 positive nodes, young, I am doing this sometimes sort of off-label. And I think it's something I do discuss with patients as long as they understand that these data are conflicting. And is it that it's abema versus palbo? Is it the duration? Is it discontinuation? We don't know. And I think it's really important for us to look at the survival benefit. But in the meantime, I do discuss this with many high-risk patients.
And you, Jen?
It's really hard for me to believe that these 3 different CDK inhibitors are so biologically different. We're not getting a hint of that really in the metastatic. But I think that we're really digging down into the differences of the design of these trials, the length of the therapy, and the patients that accrue to it. But at the end of the day, the data is where we are. And so with Monarch E being the one where we do see that difference statistically significant, if I were to offer a CDK inhibitor, it would be abema at this point.
Yeah, it may be that in our very high-risk patients where, we have some data on also safety, which seems to be reasonably safe, that combining abemaciclib with an AI is not an unreasonable approach with patients who have the highest risk of relapsing in the first 2 years, 2 to 3 years, where distant recurrence is really such a terrible outcome in these patients. So we just want to be careful. And also, until we see the data breakdown in terms of the risk of thromboembolic events with AIs versus tamoxifen, I probably would only use abemaciclib with an AI at the moment, given the fact that there was a slight increase in that risk. Mm-hmm. It is fascinating, and we'll look forward to more data. I'm sure we're going to see more data next year, even on the early use of CDK4/6 inhibitors in the adjuvant setting. And will be fascinating to see if we ever do see survival benefits, because these patients will also receive the agents in the metastatic setting as well. We're going to have interesting discussions about sequencing, et cetera. So thank you very much.